Hello, everybody. My name is Yousef Zakharia. I'm Associate Professor of Medicine at the University of Iowa, and it's my pleasure to be here to talk to you about the role of IDO or indolamine 2,3 oxygenase, dioxygenase in cancers. And the title of my talk is IDO in Melanoma Deserves a Further Evaluation. Here are my disclosures. IDO or indolamine 2,3 dioxygenase is an enzyme that converts essential amino acid tryptophan to kynurenine, which results in tryptophan depletion and kynurenine accumulation. And the outcome of this phenotype is immune suppression to the tumor microenvironment. And the tumors hijack the IDO pathway to facilitate immune response, immune escape. IDO has been associated with worse prognosis in multiple tumor types, including melanoma, non-small cell lung cancer, and multiple other tumors listed here. And multiple IDO inhibitors do exist currently in different clinical trials. Majority of them are direct enzymatic inhibitors like epacadostat, naproximod, or lenrodostat, as opposed to indoximod, which is the agent we used in our clinical trial, works at different levels, including at the different immune cells, including the pause. I would like to re-record.
No problem. Just go back to where you're ready to present, and then take about a 3-second pause.
Could I go from the beginning, because I was distracted by a phone call?
Sure. Yeah, that's fine. No problem. Just make sure you go all the way back with your slides to the first page, and then it may say push to audience once you get there.
Okay.
Okay, perfect. All right, so just take another pause, and then you can begin.
Okay. Hello, my name is Yousef Zakharia. I'm Associate Professor of Medicine at the University of Iowa and Medical Oncologist at the Holden Comprehensive Cancer Center. It's my pleasure to talk to you about IDO pathway in melanoma, or indolamine 2,3 dioxygenase. And the title of my talk is IDO in Melanoma Deserves Further Evaluation. These are my disclosures. IDO or indolamine 2,3 dioxygenase is an enzyme that converts essential amino acid tryptophan to kynurenine and results in depletion of tryptophan and accumulation of kynurenine. And the outcome of this pathway basically is a suppressive phenotype to the tumor immune microenvironment. The tumors do hijack the IDO pathway to facilitate immune escape. IDO is overexpressed in multiple types of tumors as listed here, including melanoma, non-small cell lung cancer, and multiple others. And its higher expression is associated with poor prognosis, as illustrated here in this Kaplan-Meier curve. There are multiple IDO inhibitors that exist in different stages of clinical trial. Majority of them are direct enzymatic inhibitors like epacadostat, naproximod, or lenrodostat, as opposed to indoximod, which is a drug we studied in our clinical trial, acts directly on the immune cells to reverse IDO pathway-mediated suppression. Studies have suggested that indoximab enables the effector T cells in tumors and attenuates in draining lymph nodes and results in differentiation of the regulatory T cells more towards helper T cells phenotype. Multiple preclinical data suggest the synergistic effect between indoximab and other checkpoint inhibitor, including PD-1 and CTLA-4. And these preclinical data have set up the stage for our clinical trial that we presented previously and about to publish in the Journal of Immunotherapy in Cancer. This was a phase 2 clinical trial combining indoximab plus checkpoint inhibitor in advanced melanoma. It was a single-arm, open-label study with primary endpoint of objective response rates. The main eligibility criteria listed here, including unresectable or advanced melanoma, treatment naive for immunotherapy, prior BRAF inhibitors or radiation therapy were allowed. We basically used indoximab at 1200 milligram twice daily, along with the standard of care checkpoint inhibitor, and we continued treatment until toxicity or disease progression. The trial allowed, at the time when we started the trial, pembrolizumab, nivolumab, and ipilimumab, all of them were appropriate first-line treatment for metastatic melanoma. So the design, as listed here, shows that it was a provider or investigator choice of pembrolizumab, nivolumab, or ipilimumab along with indoximab until disease progression, and we allowed at that point to switch the PD-1 inhibitor to CTLA-4 or vice versa, as illustrated here. We have treated 131 or screened 131 patients on this clinical trial, and the safety population included 114 patients. Of those were mainly treated with pembrolizumab and indoximab per provider choice. And that is the data we are presenting here. Of those 114 patients treated with pembro and indoximab, 18 patients had ocular melanoma, and we are excluding them from our efficacy cohort given the different biology compared to other non-ocular melanoma. We did have 7 patients who came off study prior to the first on-treatment imaging due to adverse events or withdrawal of consent, and that left us with 89 patients who are non-ocular melanoma treated with pembrolizumab and indoximab, and we call them our efficacy cohort. Of those 89 patients, these are the baseline characteristics, median age of 61, which is expected in general melanoma population, and majority of them were male, Caucasian. Almost 90% of them had stage 4 disease. About 10 patients had unresectable stage 3B and C. A quarter of them had elevated LDH, and 14 patients did receive prior radiation, and 16 patients did receive prior systemic therapy, including or BRAF and MEK inhibitor, or previous remote history of interferon or IL-2, but none of them received checkpoint inhibitor. This is our efficacy data in the intention to treat population of all patients treated with non-ocular melanoma treated with pembrolizumab and rituximab, we had 96 patients, and we had an overall response rate of 47% with a complete remission of 19% and disease control rate of 65%. In our evaluable or efficacy population of 89 patients who received on treatment images, we did have 51% was our response rate and 20% complete response and a disease control rate of 70%. We did have a median PFS of about 12.4 months. And of interest, we observed in the 14 patients who received prior radiation therapy, we observed 9 out of the 14 achieving an overall response rate of 64% and disease control rate of 86%, speaking to the potential synergistic effect between the radiation and immunotherapy. Granted, this is a small sample of patients and it is worth studying it further in larger population. In looking at the PD-L1 staining, we had 30 patients out of 56 we had a PD-L1 status known for 56 patients. Of those, 30 patients or 54% had PD-L1 positive and 26 patients or 46% had a PD-L1 negative. And the overall response rate in the PD-L1 positive was about 70% and in the PD-L1 negative was 46%. This spider plot shows the type of responses. As you can observe, majority of responses happened within the first 3 months on treatment. Few responses happened 6 months and beyond, and as one would expect, these responses are durable. As you can see from this swimmer plot, we do have many patients who went on treatment beyond 2 years. And this waterfall plot does show the different type of responses we had, with the green showing the complete remission and the blue showing the partial remission. Of note, we do have some patients who achieve deep partial response, and we continue to watch them on a clinical trial. The side effects profile of this combination is not outside the expectation of what one would expect with any single agent PD-1 inhibitor. In other words, as you can see here, the side effects are to be expected with immunotherapy, including fatigue in 62% of patients, and skin rash in 40%, and itching in 35%. I wanted to point out we encountered minimal grade 3 and 4 toxicity here as listed in this table, and we did not encounter any treatment-related deaths. Utilizing a pre and on treatment biopsy in 14 patients in our cohort, as listed here, in red color showed the responders, and in the green color is the non-responders. Testing for IDO positivity by immunofluorescence, we have observed that the responders did achieve downregulation of their IDO expression as opposed to the non-responders. Granted, this is a smaller sample, and it is worth studying in future trials. And breaking down these responses or these stain according to the Ki-67 positive, as one would expect in tumor cells, and negative in stromal or immune cells, we can see that majority of these downregulation of IDO is accounted for the stromal or the immune cells, and we did not encounter that IDO down expression in the tumor cells. And in looking at the Kaplan-Meier curve here in the second panel and correlating the PFS with the IDO expression, we have observed a tendency towards improved PFS in patients who had high IDO expression as opposed to the lower. But again, that was not statistically significant, and it is worth studying in further or larger sample size. We did not encounter that correlation between PFS and PD-L1 in this, as illustrated in this graph. We did RNA-seq on this paired sample in 14 patients. 6 of them had response and 8 of them without response. And as illustrated in this volcano plot, unsupervised clustering showed a clear cluster of inflammatory genes upregulated by treatment, primarily in the responders. And these genes basically related to either activated T cells, natural killers, or antigen-presenting cells, as opposed we observed downregulation in genes related to melanoma, like MAG and GAG genes. And we did not observe that phenomenon in the non-responders, as illustrated in this second figure. Other preclinical or other early phase clinical trials using other IDO inhibitor with epacadostat and pembrolizumab in ECHO 202 did show similar encouraging results in 54 patients where we observed 56% an overall response rate and 15% complete response, and a median PFS of 12.4 months. However, unfortunately, in a larger phase 3 trial comparing pembrolizumab plus epacadostat versus pembro and placebo, we did not encounter superiority of epacadostat arm compared to the placebo arm. As illustrated in this Kaplan-Meier curve, the overall survival was identical between the pembrolizumab and epacadostat arm compared to pembro and placebo, and unfortunately this put a negative impact on the IDO pathway. There are some theories why this clinical trial was negative. There is some uncertainty regarding or surrounding the dose of epacadostat that was used in this clinical trial with 100 milligrams, whether that was really the right dose to test. And in looking into the pharmacokinetics data, as you can see here, the suppression of kynurenine really happens at higher doses, at 600 milligram of epacadostat and beyond. Looking at this figure 4 pooled analysis of multiple epacadostat and checkpoint inhibitor trials, we can see, I'm sorry, it's a little bit blurry curve, but you can see the suppression of kynurenine is really happening at high doses at 600 milligrams. Nevertheless, we have learned significant lessons from this phase 3 clinical trial, whether despite the negative outcome, unfortunately, I guess the very most important or the most important lesson is, should we have a randomized phase 2 studies prior to jumping onto randomized phase 3 trials? Take it like a stepwise approach. before jumping all the way from a phase 1 to a randomized phase 3. Nevertheless, the IDO pathway is coming back now again with multiple clinical trials, including different types of malignancies. There is ongoing clinical trial currently in bladder cancer using IDO inhibitor KHK2455 in combination with avelumab in platinum in bladder cancer patients after progression of cisplatin-based chemotherapy, or if they are platinum ineligible. And there is an ongoing clinical trial in neoadjuvant setting in bladder cancer utilizing IDO inhibitor in combination with chemotherapy, as illustrated in this schema. So I guess the main message here is we do have a long history of IDO inhibition and the benefit in the preclinical model, and we do have multiple early stage clinical trials that do suggest the activity of this pathway, or the importance of this pathway in cancer, and the activity or the importance of targeting this pathway in cancer. And our results in 89 patients do seem encouraging to be studied further in larger randomized clinical trial, and we hope to see these bladder studies showing activity in the future. With that, I would like to thank you for listening.